So this is a planned secondary analysis of data from the phase 3 trials that were performed for the approval of estetrol and drospirenone for oral contraception. There were parallel studies, one in Europe and Russia and the other in the US and Canada. And because this secondary evaluation of menstrual complaints, the patients in both locations are very different patients. It was probably best to not report them as a pooled analysis, but as separate groups. So the data from the European and Russian study has already been published, and this is now the publication of the data from the US and Canadian study. For this planned evaluation, participants at the beginning of the study and at the whenever they exited completed a menstrual distress questionnaire, which is a standardized measure of complaints or how people feel during their menses. And it's used in various studies to evaluate how products or can change how people are feeling during their menses or around the time of their menses. It's also used by investigators just to evaluate how people are doing with their menses. But this was part of the study so that we could see what happened to people who were from the beginning of their study participation to the end. Now, there's two groups to look at. One are starters, which are people that had not used hormonal contraception prior in the months prior to starting the study. And there were switchers, people who already were using hormonal contraception and were switching to this device or switching to this product, excuse me. So as you can imagine, people who were already on a birth control pill may have a different baseline starting point than somebody who was not. And that's why you look at everything in two groups. Sure. I mean, the first easy takeaway is that people who were already on hormonal contraception had lower scores for the most important domains in the menstrual distress questionnaire as compared to starters. So that switchers were different than starters, and that's why they're looked at in different groups. And for this study, we focused on the most important parts of the questionnaire because there's lots of different questions in it. But there have been studies in the past that have shown that there are certain criteria within the evaluations that are more likely to be problematic for patients. So those are things related to pain, water tension, negative affect, and impaired concentration. So we focused just on those based on prior research that showed those are the things that seem to be affected the most by combined hormonal contraception. So the first takeaway is for switchers, they started differently than starters, and the switchers had no real changes throughout. In other words, they started lower in all their scores in those domains, and they stayed low, meaning that the oral contraceptive didn't make things any worse, that they were already in a relatively reasonable place and stayed there from the general way that MDQ is evaluated. For the starters, there was a decrease in symptom intensity throughout all of those domains, but there were specific ones that were easier to see significant effects. And we looked at the way the effects were measured, and we chose to report the ones where there was a decrease in symptom intensity of at least 40%. So that's really a significant decrease in the average scores. And that happened for within the pain domain for headaches, cramps, backache, fatigue, general aches and pains. So there were a lot of things that people felt better. And within the water retention domain, there was less weight gain, skin blemishes, painful or tender breasts, and swelling. And within the negative affect domain, there was a significant decrease in anxiety, mood swings, and irritability. So all these show the really positive effects. But one of the unique things we wanted to do was say, how do we put this data in a way that clinicians can use it? Because what I'm telling you now is the way that all of these studies in the past have typically been reported. Let's look at domain scores, and there's special statistics that are described for using the menstrual distress questionnaire to try to figure out if something's significant. But how does a clinician say, well, there's a decrease, but for you who is in front of me, you have severe complaints of pain with your periods, or you have mild complaints of pain with your periods. What's going to happen? And so just that there's a decrease in the average score doesn't necessarily help clinicians with counseling. So both with the European study, we started this, and with this study, we also did the same. We did something called shift tables, and shift tables are ways in which you can look at where people are starting and where they shift to. And what's that gives the clinician the ability to look at this data and say, aha, for you, this is what you would expect. So as an example, for people who were starters who had, when we looked at premenstrual cramping, for the people that reported none, about a third reported some increase in their menstrual cramping at some point during the study, but virtually all of it was mild when they ended the study. Only a very small proportion of it was worse than mild. So it shows that for most people, they don't get worse, or if they do, it's a very small percentage. On the flip side, as you start looking at people with more significant cramping, like those who reported moderate cramping, at the end of treatment, 30% had none, 17% said their cramping was mild, and 36% said it was still moderate. So only about 15% said it got worse, but 85% said it was the same or better. And in fact, about half it was better. When you look at people that had strong cramps, only 9% said it had changed to severe, but 90% it either was the same or better. And in fact, almost 2/3 of the people, it was significantly better. And then when you look at people at severe cramps, about a third stayed the same, but 2/3 get significantly better. So those shift tables allow a provider to say, based on what you're complaining of, I can tell you the likelihood this will get worse or will get better, rather than just saying, well, this is what the investigators reported as the mean decrease in score, because you don't want to promise patients, oh, it goes down in everybody. It doesn't happen for everybody. And that's true for all pills. But you can get the idea. I can maybe say 2/3 of the people, it gets way better or something like that, so that the data actually provides really good clinical information for providers when they're counseling their patients. Right. So as I mentioned earlier, switchers tended to not have changes in their scores, but when we look at those shift tables, you still see benefit. And that's what's important, because when you say no change in their scores, you're expecting everyone to stay about the same. But in fact, there is a proportion of people that get better. For example, using that premenstrual cramping example we talked about earlier, for people that had strong or reported strong premenstrual cramps, about 20% stayed the same. Only 2% said it got worse, but about 80% it got better. So even though you look at the scores and you say on average for the population it stayed the same, for people that have really significant complaints, there's definitely improvement. We saw the same thing even with just moderate cramping, whereas about 20% said that it got a little bit worse, but over half said it got significantly better, and about 20% said it stayed the same. So even in those switchers, there's a definite ability of the product to have a significant impact for people. And this way of looking at this with shift tables allows the clinician to understand that better than just looking at average numbers over a population. Well, I think importantly, whenever anybody looks at these kind of studies, these secondary analyses that use menstrual distress questionnaires for during a phase 3 study, none of this is comparative. So we don't know how this compares to other oral contraceptives or other types of contraceptives. You can't compare one study to another study because the populations are different. They're done at a different time. Like, so we even showed that the even these studies, when done at the same time in a primarily European population versus a primarily US population, there were very different results, even when done at the same time. So the only way to compare between products is to do a randomized trial in the same population at the same time. So this doesn't say this product is better or worse than anything else. It just provides an abundance of data that is reported in a way that clinicians can use for counseling their patients.